Welcome back to Anatomiqa. In this session, we will discuss on the development of respiratory system. Before we go into actual discussion of the development of lung, let us see the following questions. What stimulates the infant to start breathing at birth? Is slapping the buttocks necessary? Till what age the lung development occurs in an individual? Keep these questions in mind as you go through the session and try to analyze the answers. We will review these questions at the end of the session. The learning objectives of this session are: describe the formation of the respiratory diverticulum, describe the parts of the respiratory diverticulum that develop into the larynx, trachea, bronchi, bronchioles and alveoli. Describe the stages in the maturation of the lungs. Give examples of some congenital abnormalities of the respiratory system. Explain the embryological basis of tracheo-esophageal fistula. In the third week of development, you should be remembering the formation of the three germ layers: ectoderm, mesoderm and endoderm. The mesoderm further divides into three parts from medial to lateral end of the embryonic disc: the paraxial mesoderm, next to the notochord, then intermediate mesoderm and lateral plate mesoderm. The lateral plate mesoderm further divides into two layers: splanchnopleuric mesoderm towards the endoderm and the somatopleuric mesoderm towards the ectoderm by the intraembryonic coelom. In the fourth week, with the folding of the embryo, the three layers fuse to form a cylinder which gives the shape to the embryo. The endoderm fuse to form the primitive gut. The two layers of lateral plate mesoderm fuse with each other and separate the intraembryonic from the extraembryonic coelom, and the ectoderm fuse to form the surface ectodermal layer. The respiratory system develops from the laryngotracheal groove, which is developing in the endoderm of the cranial part of the primitive gut called the foregut and the surrounding splanchnopleuric mesoderm. The respiratory system has upper respiratory tract and lower respiratory tract. The upper respiratory tract includes the nasal cavities and pharynx. The lower respiratory tract includes the larynx, trachea, bronchi, bronchioles and alveoli. The development of the upper respiratory tract, which includes nasal cavities and pharynx, will be discussed under the development of head and neck. The lower respiratory organs from larynx to lungs will be discussed in this session. If you observe this embryo, you can see the 5 pharyngeal arches. The respiratory diverticulum develops between the 4th pharyngeal arch and the 6th pharyngeal arch. Please observe that the cardiogenic area and the development of respiratory system are very close to each other. To get the overview of how the lung looks in the histological section and the components and their arrangement of the respiratory system, here is the photograph of the section of the lung showing the epithelium lining the lumen of the bronchiole and the alveoli, which is surrounded by the cartilage, smooth muscle and the connective tissue layers. Since the diverticulum is developing from the foregut, which is formed by the definitive endoderm layer, the epithelium of the internal lining of the larynx, trachea and bronchi, as well as that of the lungs, is entirely of endodermal in origin. The cartilaginous, muscular and connective tissue components of the trachea and lungs are derived from the splanchnic or splanchnopleuric mesoderm surrounding the foregut. By the end of 4 weeks, The respiratory diverticulum or the lung bud appears as an outgrowth from the ventral wall of the foregut. The appearance and location of the lung bud are dependent upon an increase in the retinoic acid produced by adjacent mesoderm. This increase in the retinoic acid causes upregulation of the transcription factor TBX4 expressed in the endoderm of the gut tube at the site of the respiratory diverticulum. TBX4 induces formation of the bud and the continued growth and differentiation of the lungs. The diagram of the embryo shows the pharyngeal arches and the respiratory diverticulum appearing caudal to the fourth pharyngeal arch. When the section is taken across the pharynx as shown in the embryo and observed from dorsal aspect, we observe the floor of the pharynx with the pharyngeal pouches from inside. The diverticulum appears as the laryngotracheal groove from the ventral wall of the foregut in the beginning of the fourth week between the fourth and sixth pharyngeal pouches. Now let us observe only the foregut part and the laryngotracheal groove in the lateral and ventral views. That is the laryngotracheal groove from the ventral wall of the foregut, caudal to fourth pharyngeal pouch. Initially, the lung bud is in open communication with the foregut. Later, the diverticulum develops and extends caudally and is called laryngotracheal diverticulum or respiratory diverticulum. On either side of the groove, two longitudinal ridges, the tracheoesophageal ridges or folds, develop and starts separating the diverticulum from the foregut from the caudal aspect towards the cranial part. Subsequently, these ridges approach each other and fuse to form a partition called the tracheoesophageal septum. This septum divides the cranial part of the foregut into ventral part, the laryngotracheal tube, which form the primordium of larynx, trachea, bronchi and lungs, and a dorsal part which forms primordium of the oropharynx and esophagus. The opening of the laryngotracheal tube into the pharynx at cranial end becomes the primordial laryngeal inlet. Now let us see the development of the different parts of the respiratory system in detail. To start with the larynx, larynx develops from the cranial part of the laryngotracheal tube. The internal epithelial lining of the larynx originates from the endoderm of the cranial end of the laryngotracheal tube. The laryngeal cartilages and the muscles which forms the rest of the wall of the larynx originate from mesenchyme of the fourth and sixth pharyngeal arches. The cell population of this mesenchyme in fourth and sixth pharyngeal arches are derived from the neural crest. In the beginning, the opening of the larynx into the pharynx persists as slit-like orifice, which forms the inlet of larynx. The mesenchyme at the cranial end of the laryngotracheal tube proliferates rapidly and develops into paired arytenoid swellings. These swellings converts the slit-like primordial glottis into a T-shaped laryngeal inlet. Subsequently, when the mesenchyme of the two arches transforms into the thyroid, cricoid and arytenoid cartilages, the characteristic adult shape of the laryngeal orifice is formed. Simultaneously, when the cartilages are formed, the laryngeal epithelium proliferates rapidly and occludes the lumen of the larynx temporarily. Subsequently, vacuolization and recanalization of the lumen by the 10th week produce a pair of lateral recesses called the laryngeal ventricles. These recesses are bounded by two pairs of mucous membrane folds that differentiate into the upper false vestibular folds and lower true vocal folds. Since musculature of the larynx is derived from the mesenchyme of the 4th and 6th pharyngeal arches, all the laryngeal muscles are innervated by branches of the 10th cranial nerve, that is the vagus nerve. The superior laryngeal nerve innervates the derivatives of the 4th pharyngeal arch, and the recurrent laryngeal nerve innervates the derivatives of the 6th pharyngeal arch. Coming to the development of the trachea, bronchi and lungs. During the separation of the laryngotracheal tube from the foregut by the 4th week, the respiratory diverticulum caudal to the larynx forms the trachea and two lateral outpocketings, the bronchial buds. At the beginning of the 5th week, each of these buds enlarges to form right and left main bronchi. Now let us focus only on the laryngotracheal tube. The trachea develops from the intermediate part of the laryngotracheal tube that lies between the larynx and the bifurcation of the bronchial buds. With the caudocranial extension of the tracheoesophageal septum, the trachea elongates. At birth, the bifurcation of the trachea lies at the level of the lower border of 4th thoracic vertebra. The endoderm forms the lining epithelium and glands of trachea. The cartilage, muscle and connective tissue develop from splanchnopleuric mesoderm surrounding the tube. The right primary bronchus subdivide into 3 secondary bronchi, superior, middle and inferior, and the left primary bronchus divides into 2 secondary bronchi, superior and inferior, for the respective lobes of the lung on each side. On the right, the superior secondary bronchus supplies the upper lobe of the lung, middle secondary bronchus supplies the middle lobe of right lung, and the inferior connecting to the lower lobe. On the left, the 2 secondary bronchi supply the upper lobe and the lower lobes of the lung respectively. The right main bronchus is slightly larger than the left one and is oriented more vertically in line with the trachea than the left. Left primary bronchus is narrow and forms an angle with the trachea. Because of this, a foreign body is more liable to enter the right main bronchus than the left. During further development, in the 7th week, the secondary bronchi divide repeatedly in a progressive branching, forming 10 tertiary or segmental bronchi in the right lung and 8 to 10 in the left. As this development occurs, the surrounding mesenchyme also divides. Each segmental bronchus, with its surrounding mass of mesenchyme, forms the primordium of a bronchopulmonary segment. By the end of the 6th month or 24 weeks, approximately 17 generations of subdivisions are formed up to the terminal bronchioles. Before the bronchial tree reaches its final shape, however, an additional 6 divisions are formed during postnatal life after birth. These subdivisions are regulated by epithelial mesenchymal interactions between the endoderm of the lung buds and splanchnic mesoderm that surrounds them. The splanchnic or splanchnopleuric mesoderm gives rise to cartilaginous plates, bronchial smooth muscle and connective tissue, and the pulmonary connective tissue and capillaries. While all of these new subdivisions are occurring and the bronchial tree is developing, the lungs move to more caudal position so that by the time of birth, the bifurcation of the trachea is opposite the 4th thoracic vertebra. As the lungs develop, they acquire a layer of visceral pleura derived from the splanchnic or splanchnopleuric mesoderm. With expansion The lungs and pleural cavities grow caudally and laterally into the mesenchyme of the body wall and soon lie close to the heart. The thoracic body wall becomes lined by a layer of parietal pleura derived from the somatic or somatopleuric mesoderm. Up to the 7th prenatal month, the bronchioles divide continuously into numerous smaller canals. The vascular supply increases steadily during this phase. Terminal bronchioles divide to form respiratory bronchioles, and each of the respiratory bronchiole divides into 3 to 6 alveolar ducts. Each alveolar duct ends in terminal sac or primitive alveolus that is surrounded by flat alveolar cells in close contact with neighboring capillaries. By the end of the 7th month, sufficient numbers of mature alveolar sacs and capillaries are present to guarantee adequate gas exchange, and the premature infant is able to survive. During the last 2 months of prenatal life and for several years after birth, the number of terminal sacs and alveolar sacs increases steadily. The flat alveolar cells lining the sacs become more thinner and are known as type 1 alveolar epithelial cells. With the thinning of the epithelial cells, the surrounding capillaries protrude into the alveolar sacs. This intimate contact between the epithelial and endothelial cells makes up blood-air barrier. Mature alveoli are not present before birth. In addition to endothelial cells and flat alveolar epithelial cells, another cell type develops at the end of the 6th month. These cells are called type 2 alveolar epithelial cells, which produce surfactant, a phospholipid-rich fluid capable of lowering surface tension at the air-alveolar interface. Before birth, the lungs are full of fluid that contains a high chloride concentration, little protein, some mucus from the bronchial glands, and surfactant from the type 2 alveolar epithelial cells. The amount of surfactant in the fluid increases particularly during the last 2 weeks before birth. As concentrations of the surfactant increase during the 34th week of gestation, some of this phospholipid enters the amniotic fluid and acts on the macrophages in the amniotic cavity. Once activated, the macrophages migrate across the chorion or the placenta into the uterus, where they begin to produce immune system proteins, including interleukin-1 beta. Upregulation of these proteins results in increased production of prostaglandins that cause uterine contractions. Thus, there may be signals from the fetus that participate in the initiating labor and birth. Maturation of lungs is divided into 4 stages: pseudoglandular, canalicular, terminal saccular, and alveolar. Pseudoglandular period extends between 6 to 16 weeks. The developing lungs histologically resemble an exocrine gland during the early part of this period. By 16 weeks, all of the major elements of the lung have formed, except those parts involved with gas exchange. That means the parts from respiratory bronchiole onwards have not yet developed and respiration is not possible. So, fetuses born during this period are unable to survive. Canalicular period extends between 16 to 26 weeks. The canalicular period overlaps the pseudoglandular period because cranial segments of the lungs mature faster than the caudal segments. During the canalicular period, the lumina of the bronchi and the terminal bronchioles become larger and the lung tissue becomes highly vascular. By 24 weeks, each terminal bronchiole has given rise to 2 or more respiratory bronchioles, each of which then divides into 3 to 6 tubular passages called the primordial alveolar ducts. Respiration is possible toward the end of the canalicular stage because some thin-walled terminal sacs or primordial alveoli have developed at the ends of the respiratory bronchioles and the lung tissue is well vascularized. Although the fetus born at 24 to 26 weeks may survive if given intensive care, it often dies because its respiratory and other systems are relatively immature. Terminal sac stage extends from 26 weeks to birth. During this period, many more terminal sacs develop, their epithelium becomes very thin, and capillaries begin to bulge into these sacs. The intimate contact between epithelial and endothelial cells establishes the blood-air barrier, permitting adequate gas exchange for survival. By 26 weeks, the terminal sacs are lined mainly by squamous epithelial cells of the endodermal origin, type 1 pneumocytes or alveolar epithelial cells, across which gas exchange occurs. The capillary network proliferates rapidly in the mesenchyme around the developing alveoli, and there is concurrent active development of lymphatic capillaries. Scattered among the squamous epithelial cells, there are rounded secretory epithelial cells, which are the type 2 pneumocytes or alveolar epithelial cells. They secrete pulmonary surfactant, which is a complex mixture of phospholipids and proteins. Surfactant forms as a monomolecular film over the interior walls of the alveolar sacs and counteracts surface tension forces at the air-alveolar interface. This facilitates expansion of the terminal sacs, which are the primordial alveoli. The maturation of the alveolar type 2 cells and the production of surfactant vary widely in fetuses of different ages. Surfactant production begins by 20 weeks, but surfactant is present in only small amounts in premature infants. It does not reach adequate levels until the late fetal period. Increased surfactant production induced by antenatal corticosteroids and postnatal surfactant replacement therapy have increased the rates of survival of these infants. Alveolar period extends from 32 weeks to 8 or 10 years. During alveolar period, there is further increase in the number of alveoli. The alveolo-capillary membrane, also called as pulmonary diffusion barrier or respiratory membrane, becomes sufficiently thin to allow gas exchange. Approximately 95% of characteristic mature alveoli develop postnatally. To repeat, before birth, the primordial alveoli appear as small bulges on the walls of the respiratory bronchioles and terminal sacs, which are the future alveolar ducts. After birth, the primordial alveoli enlarge as the lungs expand, and there is increase in the number of respiratory bronchioles and primordial alveoli. Alveolar development is largely complete by 3 years of age, but new alveoli may be added until approximately 8 to 10 years of age. Unlike mature alveoli, immature alveoli have the potential for forming additional primordial alveoli. So in this period, there is further increase in the number of alveoli. The alveolo-capillary membrane, also called as pulmonary diffusion barrier or respiratory membrane, becomes sufficiently thin to allow gas exchange. Approximately 150 million primordial alveoli, one of the number in adults, are present in the lungs of a full-term newborn infant. On chest X-rays, Therefore, the lungs of newborn infants appear denser than adult lungs. Between the 3rd to 8th year, the adult complement of 300 million alveoli is achieved. After birth, the transition of lungs from dependence on placenta for gas exchange to autonomous gas exchange requires the following adaptive changes in the lungs: production of surfactant in the alveolar sacs, transformation of the lungs into gas exchanging organs, establishment of parallel pulmonary and systemic circulations. 3 factors that are essential for normal lung development are adequate thoracic space for lung growth, adequate amniotic fluid volume, and fetal breathing movements. Fetal breathing movements begin before birth and cause aspiration of amniotic fluid into the lungs. These fetal breathing movements occur approximately 50% of the time and only during rapid eye movement sleep. These movements are important for stimulating lung development and conditioning respiratory muscles, possibly by creating pressure gradient between lungs and amniotic fluid. By birth, the fetus has had the advantage of several months of breathing exercise. Fetal breathing movements increase in the last 2 weeks as the time of delivery approaches. At birth, the lungs are approximately half filled with fluid which is derived from the amniotic cavity, the lungs, and the tracheal glands. When respiration begins at birth, most of the lung fluid is rapidly resorbed by the blood and lymph capillaries, and a small amount is probably expelled via the trachea and bronchi during delivery. So the fluid in the lungs is cleared at birth by 3 routes: through mouth and nose by pressure on the thorax during vaginal delivery, into the pulmonary capillaries and pulmonary arteries and veins, and into the lymphatics. When the fluid is resorbed from alveolar sacs, surfactant remains deposited as a thin phospholipid coat on alveolar cell membranes. With air entering alveoli during first breath, the surfactant coat prevents development of an air-water or blood interface with eye surface tension. Without the fatty surfactant layer, the alveoli would collapse during expiration. This condition is called atelectasis. With subsequent growth in caudal and lateral directions, the lung buds expand into the body cavity. The spaces for the lungs, the pericardio-peritoneal canals, are narrow. They lie on each side of the foregut and are gradually filled by the expanding lung buds. The splanchno-pleuric mesoderm, which covers the outside of the lung, develops into visceral pleura. The somatic mesoderm layer covering the body wall from the inside becomes the parietal pleura. The space between the parietal and visceral pleura is the pleural cavity. If you can recall, we discussed these sections during the development of heart. The intra-embryonic coelom present between 2 layers of lateral plate mesoderm is inverted U-shaped, and it is continuous with the extra-embryonic coelom at the lateral ends of the embryonic disc. With the lateral folding, the 2 limbs of the coelom fuses and gets completely separated from the extra-embryonic coelom. This intra-embryonic coelom forms the pericardio-peritoneal cavity on the ventral side of the embryo. With the expansion of the lung buds laterally and caudally, the pleuroperitoneal and pleuropericardial folds are formed. The pleuropericardial fold separates the pericardial cavity from pericardio-peritoneal cavity, and pleuroperitoneal fold separates the peritoneal cavity from the pericardio-peritoneal cavity, and the remaining space forms the primitive pleural cavities. Later, as it expands more and more, It overlaps the developing heart and pericardial cavity covering it. Respiratory movements after birth bring air into the lungs, which expand and fill the pleural cavity. Although the alveoli increase somewhat in size, growth of the lungs after birth is due primarily to an increase in the number of respiratory bronchioles and alveoli. It is estimated that only 1/6 of the adult number of alveoli are present at birth. The remaining alveoli are formed during the first 10 years of postnatal life through the continuous formation of new primitive alveoli. As we start breathing after birth, the lungs, which are pink in color, changes the color gradually over the years to grayish black due to the deposition of the carbon particles. Coming to the clinical anatomy, laryngeal atresia. It is a rare anomaly that results in obstruction of the upper fetal airway. It is also known as congenital high airway obstruction syndrome. Distal to the atresia or stenosis, the airways become dilated, the lungs are enlarged and echogenic, which is capable of producing echoes during ultrasonography because they are filled with liquid. The diaphragm is either flattened or inverted, and fetal ascites, eye drops, or both is present. Prenatal ultrasonography permits diagnosis of these anomalies. Tracheoesophageal fistula is an abnormal passage between the trachea and esophagus. It occurs at a rate of approximately 1 in 3,000 to 4,500 live births and predominantly affects males. In most cases, the fistula is associated with esophageal atresia. Tracheoesophageal fistula results from incomplete division of the cranial part of the foregut. Incomplete fusion of the tracheoesophageal folds results in a defective tracheoesophageal septum, leading to communication between the trachea and esophagus. Tracheoesophageal fistula is the most common anomaly of the lower respiratory tract. 4 main varieties of the tracheoesophageal fistula may develop. The usual anomaly is a blind ending of the superior part of the esophagus called esophageal atresia and a joining of the inferior part to the trachea near its bifurcation. Infants with this type of tracheoesophageal fistula and esophageal atresia cough and choke when swallowing because of the accumulation of excessive amounts of liquid in the mouth and upper respiratory tract. When the infant attempts to swallow milk, it rapidly fills the esophageal pouch and is regurgitated. Gastric contents may also reflux from the stomach through the fistula into the trachea and lungs, which may result in pneumonia or pneumonitis. Polyhydramnios is usually associated with esophageal atresia and tracheoesophageal fistula. Excess amniotic fluid accumulates because fluid cannot pass to the stomach and intestines for absorption and subsequent transfer through placenta to the maternal blood for disposal. The other tracheoesophageal fistulas are esophageal atresia of both superior and inferior part of esophagus. Both segments are blind. Lower segment with esophageal atresia and upper segment opening into the trachea. The last one is both segments opening into the trachea by a single passage, or they can open separately. Tracheal stenosis and atresia is the narrowing of lumen, which is called as stenosis, and obstruction of lumen, which is called as atresia. These are common anomalies that are usually associated with one of the varieties of tracheoesophageal fistula. Stenosis and atresias probably result from unequal partitioning of the foregut into the esophagus and trachea. In some cases, a web of tissue obstructs airflow. Oligohydramnios and lung development. When oligohydramnios, that is insufficient amount of amniotic fluid, is severe and chronic, lung development is retarded because restriction of the fetal thorax by the uterine walls impedes lung growth. Pulmonary hypoplasia occurs as a result and may be severe. Respiratory distress syndrome affects approximately 2% of live newborn infants, and those born prematurely are the most susceptible. Respiratory distress syndrome is also known as hyaline membrane disease. Affected infants have rapid labored breathing shortly after birth. An estimated 30% of all neonatal disease results from respiratory distress syndrome or its complications. Surfactant deficiency is a major cause of this syndrome. The lungs are underinflated and the alveoli contain fluid with high protein content called hyaline membrane. This membrane is believed to be derived from a combination of substances in the circulation and from the injured pulmonary epithelium. Prolonged intrauterine asphyxia may produce irreversible changes in type 2 alveolar cells, making them incapable of producing surfactant. Not all growth factors and hormones that control surfactant production have been identified, but corticosteroids and thyroxine are potent stimulators of surfactant production. Lung hypoplasia. In infants with congenital diaphragmatic hernia, the lung is unable to develop normally because it is compressed by the abnormally positioned abdominal viscera. Lung hypoplasia is characterized by markedly reduced lung volume. Many infants with a congenital diaphragmatic hernia die of pulmonary insufficiency despite optimal postnatal care because their lungs are too hypoplastic to support extrauterine life. Lungs of newborn infants. Fresh, healthy, neonatal lungs always contain some air. Consequently, some pulmonary tissue samples float in water. By contrast, a diseased lung that is partially filled with fluid may not float. Of medico-legal significance is the fact that the lungs of stillborn infant are firm and sink when placed in water because they contain fluid and not air. So normally the lungs from the stillborn infant will sink. Now coming to the questions, hope you would have analyzed the answers. So what stimulates the infant to start breathing at birth? Is slapping the buttocks necessary? So the answer is multiple stimuli initiate breathing at birth. Okay, slapping the buttocks is usually not necessary. Under normal circumstances, the infant's breathing begins promptly, which suggests that it is a reflex response to the sensory stimuli of exposure to air and touching. The changes in blood gases after interruption of the placental circulation, such as the decrease in oxygen tension and pH and the increase in partial pressure of carbon dioxide, are other important events in stimulating breathing. Till what age the lung development occurs in an individual? It develops even after birth till the age of 8 to 10 years. Thank you for your patience listening.